In chronic kidney disease, the loss of kidney function is progressive and irreversible. There are 5 stages of CKD, with stage 5 being the most severe and end stage. Once patients reach stage 5, renal replacement therapy or kidney transplant becomes necessary. The management of CKD requires medication and a specialized diet, and the renal diet is very restricted. CKD is a major public health issue. It affects 1 in every 10 adults in the United States. Also, it affects different populations disproportionately with health disparity issues. For example, some reports indicate that African American CKD patients, there's about 40% of them who find out they have CKD shortly before dialysis becomes necessary. So this means that these patients miss their opportunity for prevention as well as early diagnosis and early intervention. We mentioned that the primary causes of CKD are diabetes and hypertension, and also glomerulonephritis, which is the inflammation in the kidney that affects the glomeruli. Other risk factors include ethnicity, family history, hereditary factors, any direct and forceful blow to the kidneys, so acute kidney injuries, that kind of trauma, and also prolonged consumption of certain medications. We rely on the marker called the GFR, so that's the glomerulus filtration rate. And depending on the stage, we have specific recommendations in terms of treatment and management. So we see, based on what the GFR is, the stages here, and the stages are going to determine what treatment we have. So how do we calculate GFR? Well, we're going to need to obtain certain lab values, and those include creatinine, BUN, as well as albumin. We also need to consider and plug in the patient's age, gender, and ethnicity. So for here, we're talking about a female patient. So we're going to be using this cofactor here. And this patient is also African American. So we'll be using this constant here to calculate. So obviously this equation is pretty complex, but the good news is that we do have an online calculator for GFR. So this would provide easy access for both patients and their caregivers in certain cases, and it would be a convenient tool to help monitor their progression. The evidence-based clinical guidelines for CKD are issued by the National Kidney Foundation and the Kidney Disease Outcome Quality Initiative, or also known as KDOQI. Many facilities use KDOQI guidelines as their protocol to determine estimated needs, especially for protein. Basic principles of treatment include treating the underlying disease and delaying progression. Because it is an irreversible condition and we cannot reverse it, we can only delay or stall it if possible. In stages 1 and 2, so the early stages, we really want to be addressing those comorbidities and deal with certain complications. For example, we want to give patients EPO replacement therapy and also supplement vitamin D in its active form to compensate for the inadequate activation and release of the hormone. But once patients reach the end-stage renal disease or stage 5 of CKD, they will have to go on dialysis or receive a kidney transplant. At that point, nutrition therapy becomes very crucial. Once they undergo a transplant, they will have to keep the dietary and lifestyle changes and also take medications to suppress the potential rejection reaction. Dialysis is the removal of excessive and toxic byproducts of metabolism from our blood, as well as excessive fluid. In dialysis, we basically replace the function of our kidney with a device, so we can call it an artificial kidney. During dialysis, we want to make sure the patient's fluid and electrolytes are balanced and maintained. The principles behind this is the same as in the natural kidney function. So we have diffusion of ultrafiltration and osmotic pressure. That determines the direction of the movement of certain molecules, whether the water molecule itself or those molecules dissolved in the water are the ones moving. We will have blood running across side by side, but without direct contact with the diastole. So the diastole is the rinsing fluid that extracts the metabolic waste from the blood. But the two solutions, so the dialysate and the blood, do not directly mix. They are separated by a selective membrane. And we can do dialysis through hemodialysis or peritoneal dialysis. So in hemodialysis, we can see here, this is a machine that's acting as our artificial kidney. It's the dialysizer membrane here. So the artery, the blood flows in and then eventually comes back. So it's still artery blood with high pressure. But then you see really what we have here. So the blues indicating the vein. But now it just seems kind of like a big artery and a big vein are joined together here, right? And we know under normal anatomy and physiology, this would not happen because an artery is an artery and the vein is a vein, and their connections are through a web of capillary vessels, so really tiny vessels. But for people who need hemodialysis, they will go through a surgical procedure to prepare the blood vessels as what we see here. So it can be a arterial venal fistula or the arterial venal graft. And basically we create an artificial connection from the big vein and the big artery, as we see here in the forearm. So here's our fistula running between the vein and so this vein here and the artery, the radial artery. And this procedure does take several days to recover from. So if it's long-term dialysis, we need to plan. And remember that from stage 4, they need to be planning, thinking about going on hemodialysis. So at a certain point, they'll need to undergo this surgery. And then once a patient does start hemodialysis, the typical regimen is 3 days a week, and each time it'll last about 4 hours. So, imagine this for anyone on this type of regimen. That would be challenging to maintain a normal life. It's almost like a part-time job, right? Also, we need to consider their transportation to and from the dialysis centers, and also the caregiving to these patients. So it can be a huge burden to both the patients themselves and the family member or other caregivers. So this is a diagram of the AVG, arteriovenous graft. So you can see here in this case, you have this white tube linking the vein, so linking the vein to the artery. So that's the graft. And in the previous figure we saw that they were directed, pretty much connected directly. So this is basically a surgically created fistula. Another way to do dialysis is peritoneal dialysis. The peritoneal membrane inside our abdominal cavity is a selective membrane. Therefore, it allows the travel of certain molecules across the membrane but not others, so it's a natural selective membrane. PD can be done as continuous ambulatory or continuous cycling. The access to the peritoneal membrane requires a catheter, and we need to use the diacylate that contains dextrose. So for this one in the workshop, we'll be talking about how to adjust carbohydrate amount in the diet because dextrose and the dialysate could be absorbed into the body. We also need to count, so because of this, we need to count those carbohydrates in when we determine total intake. And here you can see how things are done in peritoneal dialysis. So we have the abdominal cavity here and the catheter that leads in to the cavity. So it puts the dialysate in to the system, and then after a while we let it out. We drain it, dump it into a bag for the waste solution, and then, we can go through and do another round. So the dialysate up here, having gravity pull it in, and then the waste solution down here, again, working with gravity to pull it out. And we need to keep in mind that this procedure could potentially cause infection because of the access to the internal cavity that's right here.